Welcome everybody to the Northamptonshire CCG governing body meeting in public. Thank you everybody for attending this afternoon, and welcome to governing body members and regular attendees as well. I would particularly like to welcome Julie, who is with us this afternoon, and it is absolutely lovely to see you. Very, very much welcome. I note that the on-call director this afternoon is Toby. And we have received some apologies this afternoon as well. So we've had apologies from Mitten and Ruperelia, and also from Chris Ellis. And we know that Bev Messenger, our lay member, will be late this afternoon. So those are the apologies. Is anybody aware of any other apologies that I've not mentioned? Okay, thank you. So what I'm going to do now is just to look at any declarations of interest relating to agenda items. At this point, I'm going to note that agenda item 12 we will not be taking in this meeting today. So there is not a declaration of interest there, so that item will not be taken in this meeting. Any other declarations of interest? Okay, thank you. So what I'm going to do now is to go through the minutes of the previous meeting. That was the meeting held in August. I'm going to use the page numbers on the pack throughout this afternoon. So if anybody gets lost, those are the page numbers we need to use because there are some very, very hefty papers. So we need to make sure we stay located. So I'm going to go through for accuracy first. So if we go with page 4, page 5, page 6, page 7, 8, page 9, 10, page 11, 12, 13, and a little bit on page 14. Is everybody happy to confirm that that is a true and accurate reflection of the meeting that took place last time? Okay, so I'm seeing nods of approval. As we have done with previous meetings, if you wish to approve an item, obviously we would ask you that you put yes in the agenda, in the chat bar, and then that is approved. So I'm going to start going through the matters arising from the minutes last time. Can anyone see any matters arising that are not on the agenda? I think they're all there. And if we go through the action log, most of those are green. I think the only one that is red on the action log is action GB 202148, which I think is with Stuart. Do you want to comment on that one, please, Stuart?
Yeah, sure. Thanks for that. Really the update is, due to competing priorities of the exec team over the last few weeks, we haven't done this bit of work, so we'll have to bring it back. Everybody's been very busy doing the plans and everything that this would then feed from as well. So the risk to delivering that plan. So seek forgiveness, Chair. Forgiven,
but it will stay on the action log and doesn't get dropped. So yes, that will go through to the next meeting. So thank you. And everything else is green on there. The next item on the agenda is the Chair and Chief Exec's report. I'm going to take this as read. There are a couple of things on there that I think particularly are worth me drawing people's attention to, and then I think Toby's got a couple of things that he wants to mention as well. I think it is really important that we continue to support the seasonal flu campaign. That is something we would very much encourage those who are eligible to take advantage of that vaccination, and that's something I think that's important to emphasise. I think it's also really important to emphasise self-care and both physical and mental well-being, and to make sure that people look after themselves. This is a difficult time, and I would very much urge people to look after themselves in the context of the things that are available, and we do appreciate that this is a difficult time for a lot of people. I'm going to hand over to Toby at this point because I think there was something to update us with.
Thank you, Joe. Thank you, Chair. A couple of things I just wanted to make reference to, if I may, and then I'll come to the item that Joe was referencing there. Two elements from the paper, actually, I just wanted to draw to people's attention and make a slight link to. There's an update within the paperwork in terms of children and young people's services. And I wanted just to make a link here to an event that's taking place on the 3rd of November, which is a Children and Young People Summit, which is being convened jointly between Health and NCC, the County Council. I think this is a really welcome move. I think lots of us for some time across the county have been very keen to get into a more strategic conversation about the future of children and young people services, how health and care works together in a more integrated way. And I'm really keen to encourage quite wide actual attendance at that summit from across the CCG. So I've already picked up with Ange Dempsey in terms of her portfolio and safeguarding, Alison's portfolio, particularly from a health and care partnership point of view. I'm also keen to see if we can get Emma Donnelly and people like that involved from a clinical lead perspective in terms of the work we do here. So I think it's a really welcome move to start to take a more strategic approach across health and care linked into the partnership around children and young people services. So the first thing was a bit of a plug for that, Joe, and particularly for those folk who might be interested. If there are others listening into the meeting today who think that might be for them, then please reach out and we can share the details of that. Second thing from the paper I just wanted to touch on was the infection prevention and control training update, which have been provided by Angela's team within this. It's only a couple of sentences, so it would be easy to kind of pass over, I guess, the significance of this. I just wanted to put on my record my thanks to Angela and to her team for leading this discussion across other local health and care organisations. There's going to be a programme of around 20 people working as part of a Royal College of Nursing course for infection prevention and control. And I think that level of commitment that Angela's been able to kind of bring together with the Director of Nursing colleagues across the system, again, it is really welcome and something that I think is going to be important for the long run in terms of the world that we're now operating within. So wanted to draw attention to that. Quick summary then from me, from a chief exec perspective of, I suppose, the things that have been preoccupying our minds over the last month, kind of the month it's been since we were last together. And actually today's agenda reflects these very much, Chair. So firstly, as Stuart's already referenced, the focus on phase 3 planning for the NHS in terms of restoring non-COVID activity, particularly elective surgery, which I'd say we've been doing very well at from a county perspective with our providers. And also planning the financial position for the rest of the year in a very uncertain set of circumstances at the moment. So big thank you from me to Sarah and to Stuart for the work that's been underway on that front. Second kind of big area of focus around, no surprises here, around COVID response, but also around preparing for winter and around flu, and also thinking ahead a bit to EU exit as well into early part of next year. So again, a significant focus of work across both the clinical and executive side of the organisation in terms of our preparedness here. And again, we'll touch on that later on the agenda. And then thirdly, important piece for me around continuing the focus on the development of the integrated care system work and the health and care partnership. And Alison Gilbert in particular has been working closely, I'm delighted to say now, with our newly appointed independent chair, Naomi, who started with us last week, which I think is a great move and really, really welcome in terms of that independent perspective she'll bring into that role. And that, again, is going to help us to move forward some of that health and care partnership work. And then the fourth area I just wanted to acknowledge in terms of core areas of focus over the last recent weeks has been around how we continue to support all of our staff from a CCG perspective. And I include that in the broadest sense in terms of both our clinical leads as well as our lay members, as well as our core employed staff and those CSU staff from NEL that work with us. We got quite close during the last month to actually moving towards a larger number of people being office-based again within some of our core headquarter offices. Quite clearly, given the change in national position around office working in terms of government policy, we've stepped back from that. But it does mean I'm very conscious of the effort all of our staff are putting in, working in what are really very unusual circumstances and balancing that alongside families and other sort of home and domestic arrangements as well. And I think we probably all sense as we go in further into winter, the kind of challenge of that emotionally and mentally as well, in terms of working in what for a lot of people are quite isolated ways, is something I'm very mindful of our employers' responsibility to all of our staff. So as you can tell from all of that, it's been a very busy month with a lot of activity, and we'll touch on many of those areas on the agenda. In the midst of all of that, though, I just wanted to share something that had come in as a little ray of sunshine, and I don't say that lightly or glibly, in the midst of, I think it was the middle of last week, wading through preparations for stepping up COVID response, preparations for how we deal with the financial challenges we've got. And in the midst of all of that, someone in the office opened up the post and brought into my office and popped on the table a card that had been received, sent into the CCG as a thank you card. And I think we're able to share it on screen. I think, Emma, you might be able to do this for us. Is that possible? I think we've got Emma for us on screen. That might be a no. I was hoping that the technology was going to allow us, because we'd scanned in a version of this, to be able to have shared it on screen. I'll tell you what it is in case it is able to pop up in a moment. We had a thank you card that came in, and I'll actually read you the words because I've got it on screen in front of me. It came in and said, "To all at the Clinical Commissioning Group, we would like to express our deepest gratitude for funding our IVF treatment. Thank you for making it possible to welcome our little girl into our family. We will be forever grateful. Best wishes." And it was one of those little moments, and actually there we've got it on screen with names appropriately kind of of that. And it was one of those little moments that just reminds you of how the work that we all do touches on the lives of people across the county. And I can genuinely say, I think in my 8 years as a chief executive of various commissioning groups, I think it's also the first direct thank you card that we've received back in quite that same spirit. And on a day that was otherwise pretty heavy with a whole load of other stuff that was going on in a typical long set of hours, it was a real little reminder that actually the work that we do in so many ways touches on people's lives, and it was great to see that kind of gratitude reflected. We will be writing back because we did have name and address provided to us in terms of the family, so there will be a little note going back from Joe and myself just to acknowledge how much that was appreciated, and I'm glad I've been able to share that with you all, and thank you, Emma, for doing that on screen for now as well. Thank you, Joe. Happy to take any questions on any of the above or the attached report.
Any questions on the Chair or Chief Exec's and Chief Exec's report? Yeah, thank you. Thank you, Toby, for sharing. Oh, David?
It could have been said now or could be said later, but from a HealthWatch perspective, to thank yourself and Toby and others from the health world for the collaborative way in which the COVID issues are being managed and the oversight board is run. That is being chaired by a county councillor, and he does that in a very inclusive and partnership way. But when you think back over the difficult things of partnership working there have been in Northamptonshire, the fact that that COVID board is working so collaboratively, and we had a very constructive collaborative discussion on Friday, I'm sure that we'll come back later. And it is so important to maintain that collaborative, inclusive approach to how we manage this. But that is a tribute to people from the health service who have worked hard to build those partnerships and that trust. And that is precious and it's to be nurtured. But thank you.
Thank you very much, David. That's very much noted and extremely welcome in itself. So thank you. So I'm going to move on. We do not have any questions from members of the public. So I'm going to move on with item 8, which is Lucy, who's going to tell us obviously more about the incident response, and obviously we have got the extensive slides as well. Over to you, Lucy.
Thank you, Chair. And then I'm sure Sarah Stansfield may want to come in and talk about the CCG specific response. But if I give a little bit of context, and I'll take the report as read. So for those that haven't seen this type of report before, this is a weekly surveillance report that we publish on the Northamptonshire County Council website. And basically it gives the public an update from a point of view of the current COVID statistics, cases, direction of travel, but also ensures that they have links to the latest government information around requirements, restrictions, guidance, but also gives an update on what we're doing locally. So I'm hoping that the public do find it useful. But obviously it's not painting a pretty picture in the last week. So the data is usually about a week and a half behind. So people will note that this is data up to the 4th of October. And in the 7 days up to the 4th of October, Northamptonshire had actually experienced quite a significant spike in its cases and had registered 417 positive COVID cases that week, bringing the total since the beginning of the pandemic to over 5,500 cases. Where we had historically had very much focused high rates in our more deprived and more densely populated towns, we certainly are starting to see the borough and district position change across all 7 areas. And in the week up to 4th of October, there was an increase in cases across all 7 boroughs and districts. Interestingly, we've also been providing data about the gender split and also the age group, so in 10-year age bands. Obviously, with return to school and university, we had seen an increase in younger age group, but quite concerningly, in that last 7 days up to the 4th of October, we'd also seen an increase in an older population in cases aged 50 to 59 and then over 60. And sadly, that is also starting to translate into an increased number of admissions to our hospitals, and also, very sadly indeed, in death. From a point of view of rates locally, we try and make them comparable. So we create a rate per 100,000 population so that you can look at the differences between boroughs and districts. And again, you can see that they're increasing overall. Our Northamptonshire county rate is also increasing. And I think one of the things to just point out here is, although we remain statistically significantly lower than the England average, that is obviously very heavily skewed by the extraordinarily high rates that we're seeing in the north and northwest. So it isn't a comfortable place, and I don't want people to be complacent about the fact that we have better rates than other areas. We still are seeing a significant spike, and we're now talking about the kind of rates that were 3 or 4 weeks behind where Manchester and other similar areas were, as I said, about 3 or 4 weeks ago. So we know this can escalate very quickly, and therefore obviously we are making recommendations that people do adhere to all of the national guidelines, but on top of that, that they limit mixing between households as much as possible, because all of the evidence locally suggests this is primarily driven by contamination and cross-infection of people within households, but also then infection between one household and another. So just because you can do certain things at the moment, being in a level 1 age, doesn't mean that you should. And we're really reinforcing that message coming up to half term. We also have evidence that sleepovers, etc., in school-age children is driving some of the high numbers in that younger age group. And again, socialising in younger adults, also again causing some increases in our case numbers. So just because you are able theoretically to do this as a level 1 area doesn't mean that you should be, and people need to understand the implications not only for themselves and the risk that they're exposing themselves to, but also the more vulnerable people within their family and the wider community. In the week up to the 4th of October, we had also been providing education status updates because of the recent opening of schools. People will see that at that point we had 4 school outbreaks. That is increasing week on week. The numbers associated with those outbreaks was relatively low. And thankfully, we only had 10 confirmed cases within our university as well. So although, again, a positive picture, it is quite a rapidly escalating picture. And people will see in this week's update that those figures are increasing quite quickly. We do provide a breakdown from a point of view of case rates and cases by areas, so the public are able to understand if they live in an area that has a higher risk than perhaps other areas in Northamptonshire. And then finally at the end, we provide a breakdown in more detail of all of our outbreaks. So as I said, we've touched on school settings, but we do still continue to work with our care home provider market to ensure that the proactive swabbing process that is in place nationally, where they're swabbing residents and staff, that we provide assurance and information and support should they find any positive cases, to ensure that those obviously are not passed on to other residents and vulnerable people living in those settings. But we are also experiencing a slight increase in workplace settings. Again, a small number of employees involved in each, but it does just demonstrate, again, when we're talking to these people and finding out where they've potentially contracted the virus, often it's not the workplace setting itself, but it's by mixing between households and with somebody else within their family who's been positive. So again, just asking people to be vigilant and obviously adhere not only to the national guidance, but really question, just because they can do something under those restrictions doesn't mean that they should. I know there's lots of other information in there, but I think rather than keep going through it in detail, I'm happy to take any questions.
Thank you, Lucy. And as I say, as noted, this is something that's available for the public to view every single week on the County Council website, and is very much appreciated, I know, by a lot of people. So I've got a question from Ange.
Yeah, thank you, Lucy. And just to put it into context as well, I spoke to quite a few care homes last week, and they were feeling quite confident around their testing, Lucy. They were feeling that it's working really well for them, but they did actually point out lots of them have not had any outbreaks amongst and only minority had had them with staff, but those that had contracted COVID was outside the care home setting. So they were very proud. Many of those care homes were so proud that they had no outbreaks whatsoever and had really managed it. But they knew that there is a risk because often the contraction of the virus is outside the care home, it's out of their control. So it actually does fit with the picture, and that's what the care homes are saying. Obviously, they welcome testing. They're very comfortable with it now. And many of the care homes that I'm working with are really interested in having relatives tested as well. So, they're feeling confident enough to take that on as well, Lucy. So I just wanted to let you know that the care homes are feeling they're getting the support they need to manage the situation. But obviously, outside the work setting, it's very much out of their control.
Lucy, did you want to respond to that, or are you happy just to leave it to as Ange's comments?
I mean, I'm happy to leave it as Ange's comments, but Ange does make one really good point, which I'm happy to reinforce. Although we may be seeing a slight increase in our care home outbreaks, that is because we've got a proactive national swabbing process. Quite often these are asymptomatic residents and staff. But the other thing is, to put it into context, we have over 300 providers in our county. So this is a really small proportion of our provision locally, and care homes and other types of providers should be very proud with the way that they have managed this.
And also, Joe, if I just could come back, because we are part of the visiting professionals, the pilot. We're 2 months in, and I am really proud to say we've had no cases. So the staff that have been going into the care homes have been COVID free, and they get tested every week, and we've been part of that pilot. So I think it really shows that when people do have good training in place and good processes, it does make a difference.
Thank you. Philip.
So yes, I've been dealing. It's a question really for Lucy, if that's okay. I've been dealing this week with a family whose the wife's husband has been in Northampton General for 6 weeks now, and has had no visitors at all during that time. He's had a profound stroke, and when he comes home will need considerable community support, which ordinarily the family would have been trained in, but discharge is planned without any of that training. If the ambulance had taken him in a different direction to an adjacent county, the arrangements would have been quite difficult. If I can explain those, because I think we need to put some challenge into the system. In the adjacent county, what happens is that each of the wards have 1 hour visiting slots, and they have on average 4 of those a day, with half an hour in between for visitors to get in and out. And it's 1 patient, 1 hour, 1 visitor each day. Quite simple. And the hospitals have set up arrangements for the visitors to be met and taken into the ward, given appropriate labelling. And so the patients have that personal contact, and I know they're not getting that in NGH or KGH, and so presumably this is a county-wide policy. And it just seems to me we've had the issue of patients in nursing homes not seeing their families and relatives. When I heard this story, it seemed heartbreaking to me for this woman and her husband, and I just wonder whether this is a situation which we should be challenging, particularly since it appears that the public health advice in an adjacent county may be different to that which is being offered within Northamptonshire.
Ange, did you want to respond to that one?
Yeah, I really do want to pick up on that, Philip, because in actual fact we had this discussion at our strategic safeguarding forum on Friday, and one of the things my colleagues at NGH and KGH, the directors of nursing, were speaking about is visiting, Philip. In actual fact, in terms of, I mean, I'll be honest with you, some of them are very sad situations when someone's end of life, and the relatives come in and then it's too late. They're not able to have those really meaningful conversations. So in fact, we had a really open and frank conversation on Friday and bringing it to the ethics committee so that we can try and have a Northamptonshire view on visiting. We've looked at care homes, and we addressed that again in the care home cell this morning. We spoke about visiting. I think hospitals, we need to speak about that as well, because the directors of nursing are openly talking about that now, because not one size fits all, Philip. Everybody's situation is different, and we need to have some sort of arrangements that are suiting families like you've just spoken about. So I just want to assure you it is on the Director of Nursing's radar. I'm escalating it to the Ethics Committee, and hopefully I will be able to have some feedback for you. But it is something that before you raised it, I was hoping to bring something together across the whole of Northamptonshire that looks at visiting.
Okay, so they do have individual ward requirements, because
yeah, they do
ward to ward, but the concept is that there's no more than 5 visitors on ward at any one time, which I would have thought is manageable in a county which has very similar COVID levels to Northamptonshire. So it is a plea that this is looked on in a positive way, please.
And Philip, if there's anything that you can share with me, I will take that to my Don's meeting this week, and I'll share that, and maybe we could build upon that.
Thank you. Lucy, did you want to comment on that particular point?
Yes, absolutely. So unfortunately, Philip's made an assumption that's incorrect. So there is no local policy. What I have recommended is that we don't have visiting at this point in time because of the case rate increase. But this is at provider discretion. It's not something that we can enforce. You can't enforce that until you're in a level 2 area. So it's purely a recommendation. But whilst we had a period where our case rate was lower, providers, I withdrew that recommendation. Providers were encouraged to allow visiting, but some providers chose not to do that because there is a risk to their staff and obviously to other patients, not just the patient that they may be visiting. And they also need to take into consideration the restrictions that there may be of the physical environment. Not all hospitals have the staff availability to be facilitating visiting, or nor the space. So it isn't a one size fits all, as Ange says, but it also means that one size doesn't fit all if there are examples elsewhere. So whatever we do, it's got to be supported by the providers themselves, and that be that care homes or acute trusts or mental health trusts even. But it's got to work from a point of view of minimising risk, having the physical environment to do so, and also having the staff availability to do so. So it is multifaceted, not as simple as it would seem. And as I said, we have had both a recommendation not to and freedom to do so, and providers make their own choice in that. It is not a public health policy.
Sorry, Lucy, perhaps I didn't express that very well. I just assume that since KGH and MGH are doing the same thing, that then there probably have been some discussions within the system about it. That's what I think
between the two trusts, yes, absolutely. But as I said, even when they've had the flexibility to do so, they haven't always been able to facilitate that, but it is at provider discretion.
Okay. I'm very aware Toby's been patiently waiting. David, is your point related to this, or is it a slightly different one?
No, it's just a very quick point to say, I think we have to assume that these circumstances are continuing for months, and it's not going to be short. And so we have to think about balancing off, and this is the ethics issue, family connection and risk of infection for months. And I think the impact we all understand, on families of not having contact for months is going to be very serious. Now, clearly, I take all of Lucy's comments and others about needing the protections, but we have to prepare for this to go on for months, if not years. And we have to think about how we balance that, and it's going to need new ways of working. Just from HealthWatch, this is possibly one of the most important things that's affecting people in the community now, how they make those contacts with family members who are ill. And we need to apply ourselves to it and plan for the long term. Thank you.
Thank you. Toby.
Thanks, Joe. Thanks, Joe. I want to make a couple of kind of context points about where we are at the moment, add a few bits of detail into Lucy's kind of summary of current position, and then just to give her a heads up, I did want to bring Sarah Stansfield in as well, just to share with board where we are at the moment in terms of some of the work around CCG role over the next period in terms of local operations centres. I guess and before doing all of that, actually, to say, I think the conversation we've just had, and I think Philip raises a good point, and David's perspective likewise is helpful, strikes to the challenge that we've got now, which is how do we manage over the medium to long run with a set of arrangements that are causing all sorts of other implications, non-COVID related, mental health related, access to families, isolation related, at the same time as balancing that with the risk of harm from a sort of direct COVID related and a virus perspective. And we've all seen over the last week in particular the kind of intensity of that debate nationally, politically, around the balance between the economy in terms of activities of daily living, in terms of people's normal routine lives, and in terms of the risk as we go into a kind of winter period. The context bit, I suppose, I wanted to share that adds to Lucy's perspective there on what the numbers that are COVID related tell us is, if you look at where we are from a county at the moment, from a health and care perspective, of course, when we went into the first wave of COVID and we went into the initial lockdown period, the context was very, very different. We significantly freed up and created acute hospital capacity. We stood down significant levels of normal non-COVID routine activity, redeployed staff into other areas to be able to cope and deal with that. And in addition, had, and this isn't a party political comment, it's just a statement of reality, had pretty much a national public and political consensus on what the right things to do were in terms of the balance between saving lives, protecting the NHS, etc. We are now in a very, very different context. And the reason for sharing that is it means the job of us as an organisation and us as a system in terms of how we respond to this is much more finely balanced and nuanced. So if you look at where we are today, we've started seeing COVID positive admissions into our 2 acute local hospitals increasing. The numbers, thankfully, are still relatively small compared to some other parts of the country. But for me, the alarming bit is the doubling kind of rate in that. If you look at the rate at which we've moved from less than 10 cases across the 2 acute hospital sites to a position of more like 25 in a very short space of time, and also the number of cases that are then presenting in terms of ITU requirements more intensively as well. And if we then look at what's happening from a community transmission point of view, and if we look at those other parts of the country that are probably 2-3 weeks ahead of us, you can see the potential for this to ramp up very rapidly at precisely the same time that we don't have that buffer from particularly an acute bed-based perspective that we created as we went through that initial period into lockdown. So the reason for sharing that is not to be gloomy, because I'm not. I think we've learned so much over the last 6 months. I think everything David says about the way as a system partners have come together is absolutely true. But it does mean this, I think, is a more difficult 6 months we're going into, frankly, than the 6 months that we've come through in terms of how we balance that kind of competing range of things in a situation where our margins are much tighter in terms of the potential for one level of activity, whether it's COVID, whether it's what I might call routine winter pressures, or whether it's the elective activity that we're trying quite rightly to get back on top of again, because we know that's causing pain and harm in terms of further delays to treatment for people. And I really wanted to share it as context, because I think much of what we're going to discuss on today's agenda is in the arena of how, whether it's phase 3 planning, whether it's the things that we're doing from a system perspective, how do we respond in the midst of that? Before I turn to Sarah, just to describe some of the local response arrangements, I also wanted to make a link to the phase 3 planning work, because there's a really important link here, particularly from a financial perspective, that Stuart may want to add to either here or later in the meeting, which is to say that the arrangements for funding of our COVID response over the next 6 months are very different to those that we've had over the first 6 months. The initial period of this year was effectively a kind of claiming in arrears for costs that have been incurred through a national process. And most of those things have been supported in Northamptonshire to date. The second half of the year is more of an allocated approach, where we have a block of resource allocated to us as a system, and we need to work within that. And so the financial plans that have been worked through at the moment for the second part of the year I'm pleased to say we have worked very hard to be able to protect funding in the things that we know we're going to need that capacity to support. And that includes, for example, and I know Julie Curtis and I were discussing this only earlier in the week, maintaining funding in place over that next period in terms of, I think, what we previously called sort of primary care hot hubs and that kind of capacity in terms of sort of hot clinic space and equivalents if they are needed over that period. So it was a bit of a scene setter really for me, Joe and Chair, just to say so much of today's agenda is interconnected, but I know none of us do, but we shouldn't underestimate the challenge of the next 5-6 months, because I think in many respects it's a trickier balance in a very different public and political climate to the one that we've just come through. But Sarah, do you want to say a little bit perhaps to board around the arrangements that have been put in place in line with our regulators' expectations of roles over that period? Thank you, Chair.
Sarah?
Thank you, Toby. So just in terms of where we go next, if you like, as a system, NHS EI, in terms of the regulator, have asked that, as distinct this wave from the last, we approach the second wave with a local operations centre model. So each system from a health and care point of view should have its own system coordination arrangements in that kind of a model. It's actually very similar in many ways to what the Northamptonshire system did previously, but that was distinct and different from a number of others at that point. So currently the CCG is working through the resource requirements to run that model, which will look like a team of people 7 days a week. Currently, given the status of the incident for the NHS, that will be, I think it's 8 till 5 and 8 till 5 weekdays and 9 till 4 Saturdays and Sundays. But we've been asked to be able to stand up that coordination capacity 7 days a week, 12 hours a day, if and when the incident escalates and requires that. So working through with colleagues in the CCG and across the system, the resource requirements to run that coordination function, but also the leadership for the new cell structure that we're going to put in place. So some new cells this time around urgent emergency care, around the maintenance of elective throughout that period, but also the standing back up more formally of some of the cells from the first wave in terms of workforce. And also some of those cells have continued to run all the way through, for instance, primary care. So really just to say we've kind of gone through a health group, that model, the system all signed up to that. And so working through at the moment, as I say, the implications of standing up that local operations centre with a view to try and do that over the course of the next 10 days or so. So that's just kind of where we are from a local response, governance and coordination point of view.
Thank you, Sarah. That's really helpful. Toby, did you want to come up back on that point, please?
Just a very quick point to add, which is as part of those arrangements we've discussed both as a team and with you, Joe, and others, absolutely keen to make sure that we've got our clinical leads completely embedded in those different areas of work as we step that up. I think one of our learnings from first wave on this was we probably stood a few things down a little bit too quickly. It took us a while to remake some of those connections. So I'm really keen to make sure that our clinical leads, both from a locality perspective on this call, but also some of our commissioning leads, continue or sort of step back into being really embedded into that set of structures. So I think, Sarah, it would be helpful for us to share that with other board colleagues and clinical lead colleagues as well, to make sure that we've got those links and that we've got kind of everybody leaning into the same direction, given all the reasons I've just described about why that's going to be so important this time round. Thanks, Joe.
Thank you, Toby. So we've got a comment from Amar and then Philip. Amar?
Oh, hi, Lucy. Thank you for the summary. I just had a couple of quick questions, really. One was regarding the Test and Trace app. Do we get any further breakdown, or do you get any further breakdown of the data in terms of how useful that is as a tool? Obviously, we hear a lot of press headlines, some negative, some positive about the app, and we're trying to obviously encourage our patients to download the app, to use it, to aid, our fight against the virus. So I just wanted to know whether you get any data from that point of view, and whether that's showing you anything in particular as a trend in the county. And my second question was, is the data robustness in the pack that you provide similar or to the ONS data that they publish, or are we is, for example, one data set more superior than the other? I'm just interested from a understanding the numbers point of view. Thank you.
Thank you, Amar. Lucy, are you able to answer those?
Yes, of course. So firstly, the app, yes, the ambition is that we will start to get data about how many people have downloaded it locally. At the moment, we don't have that information, but we do know that businesses locally have engaged with it really well, not just those that obviously are required to display a QR code, but a lot of businesses locally have chosen to download QR codes so people can, you know, have some security and safety when they shop or when they attend their workplace. So that's been really positive. As I said, the national ambition is that we will start to get more granular data about usage locally. What we do obviously get though is information through the national test and trace process. And at the moment we get information after 24 hours, and then our local contact tracers follow up those that the national team weren't able to contact. So that's on an average day, it's about 30% of the cases that come through, they don't manage to follow up, and we do that locally. So again, adding a lot of value, because what we're able to do is go through an information, a sort of questionnaire with those people and find out where their likely exposure was. So it isn't just about identifying who they may have been in contact with and getting them to isolate, which obviously is a key element of it, but it also allows us to gather some soft intelligence about where local hotspots are, what the behaviours are locally that are driving case increases, and that fundamentally informs obviously some of the decisions that we make and the recommendations we make and the comms that we develop. So it's a really important part of the overall test and trace process. But the app data specifically, we are told it's coming, and I'm happy to share it as and when it does. With regards ONS data, they do have the same data source, they just process data in a slightly different way. Obviously the way that JBC, so the Joint Biosecurity Centre, Public Health England and the Secretary of State makes their decision, is based on the .gov data. So although we monitor both, we utilise .gov data sources as the key data source, because, as I said, it means that we're looking at the same data and numbers and rates, etc., that the government would be when decision making about what areas, different levels, you know, what levels different areas should be in. So it's not that one's more superior to the other, they are used slightly differently. But if you want to align yourself with the decision making, I would recommend the .gov data sources.
Thank you. A very comprehensive answer, much appreciated. I think probably a final point from Philip, and then, as I say, we will move on with the other items on the agenda. Philip.
Yes, Joe, it's something which we actually discussed a week ago, and I haven't seen any update on it. And I listened carefully to what Sarah was saying, and I didn't mention it. But that's the increasing need which we're seeing for community support. So I've had patients who are either COVID positive or having to isolate because of contact, and had difficulty with medicines deliveries to them last week. We haven't actually had any need for food parcels at the present time, but certainly our social prescribers are getting increasing contacts and requests for contacts from people who are either lonely or developing mental health problems. And I just want, where we've got to as a system, I used to have regular contact from the district councils about that, where we've got to as a system, particularly bearing in mind that quite a lot of patients are effectively going to need to shield in the future.
So I think I'm going to just slightly steal Lucy's thunder from the point of view that there is no shielding planned at this point. I am in contact with the Community Resilience Forum, which is the forum that has previously coordinated all the work across the districts and boroughs. That work is likely to be setting up. In particular, they are validating their list of volunteers and the people who were so fabulous and did so much hard work in the first phase. I have given your names. They will be in touch with you as locality leads. You're going to be back on duty, and that is very much stepping up, very mindful of the enormous needs within the community. Like you say, not necessarily food parcels, but connecting people with local services, allowing people to claim payments when they need to be self-isolating. There is a huge amount of work that is going on. That is absolutely stepping up again. At this point, we obviously have considerable support from social prescribers within the PCNs across the entire county. I think it's a really important resource, and obviously all practices have access to those social prescribers. They're a really important link within this, but there is a lot of work that is about to start again. They will be in touch with you. I've given them your name. Lucy, would you like to add anything else into that?
Yeah, so just, I mean, clearly people aren't aware, although the formal shielding list and therefore the overall community resilience programme associated with supporting those that were formally shielding has stopped, we've maintained at Northamptonshire County Council a community resilience service. There's details on the County Council website about how you can access support, both from point of view of food parcels and medication deliveries and support with your mental health. Those services are not stopped. But one of the things that we are adding in, because we've recognised that people aren't aware that those things still exist, is our local contact tracers do send out a text now also to the people that come through our local contact tracing process, again just directing them to information about what support they can get, because there also now is obviously a payment that people may be able to access subject to eligibility if they're having to self-isolate either as a case or a contact. So there's evident that there's sources of support out there, but just making sure people have got that information.
And I think it's probably an example a bit like the continued primary care availability that actually has been available throughout, has not stepped down, and yet there is a public perception that it is not there. So general practice is still there, community resilience and all of the volunteer and council support services all still there. All of that is still valid, has not stepped down. Thank you. So I'm going to move on with the next item that's on the agenda. So the next item is the phase 3 plan, and that's for Sarah. And to say liberties with the time, we will make up some time later on. Over to you, Sarah. You're on mute.
I'll aim to do the intro fairly quickly and then open up to questions if there are any. Conscious that this item, as was drafted for the papers, is simply an exposition of the final plan that was submitted at the end of September. It has gone through now a number of our governing body subcommittees for people's information. It's been scrutinised there. I would just pull out a couple of things. One is the challenge that that plan lays out around the recovery of elective care. And the recovery of a number of performance targets, actually wider than elective care. But also, as Toby pointed out earlier on, that actually for September, our performance against that showed some encouraging progress in the short term. But also, and I think Stuart will come to this under the financial item, the financial position in that plan has now changed. So I won't do that under this item. I'll let Stuart pick that up under the item later on. So what you've got in the papers is the final submitted phase 3 plan and also the Northamptonshire System People Plan. And I'll leave it there, Joe, take the papers as read and open up to questions or comments.
Thank you. Any questions or comments? It is obviously a vast quantity of information. There may need to be a distilled, easy read version for some people, but certainly really, really comprehensive. Any questions or comments?
I'll just jump in, Joe, with this is the easy to read version. There is a significantly longer one as well.
Okay, point taken. Anybody else have any comments? Philip, you got in first.
Okay, yes, I mean, it's a huge plan, and it's only when you see parts of it working that you realise, you know, what's actually going on there. So I mean, it's very reassuring. We've got the breast screening team in our car park at the present time. They've been working Saturdays and Sundays to get the list down, and they're now, despite being closed down for a long period of time, they're about 2 months behind. And people are putting huge amounts of effort in to restore the services that we need, and that's a really good example about it, which I've been really impressed with.
Thank you. Toby.
Thank you, Chair. 2 quick comments. One, just in terms of approach of how this has been put together. It's been notable in terms of feedback from our regulators, NHS England, that they have seen a significant change in this planning exercise compared to previous exercises that we may have run across Northamptonshire in terms of particularly NHS organisations working together through that. And I think it's interesting because, and thank you to Sarah and team and colleagues at the CCG and Stuart and others who very much coordinated this process, because it fits very much for me with the mould of where I think the role the CCG resource plays in an integrated care system going forwards over the next few years, which is very much that strategic planning and coordinating and convening kind of function. And I think this was a good demonstration of that in action that was recognised and valued both by our local partners, but also by our regulators as well. So just a process point there. Second point, this is a huge amount of detail in here. And as Sarah says, this is the easy read version. There's a more comprehensive version and as ever, a series of spreadsheets and templates as well that goes with it. But it is a plan that represents a point in time inevitably, and it represents what I suppose I might describe as a best endeavours plan. These are the things that we wish to do and are committed to progressing and taking forwards. But in conversation with national director colleagues only last week, as a group of chief execs, we had a very open conversation about our best endeavours to continue to do and sustain as much of this for as long as possible in the face of the inevitable pressures that we think are probably heading our way around COVID and around winter as well. And that's why this kind of window that we've been in and are still just about in Northamptonshire is so important to keep the focus on that. So I'm actually pleased to hear Philip's feedback there on just one particular service area of how you can see the teams and staff across the system working so hard to try and make back some of the ground that we lost in the first 6 months of this year. Thank you, Chair.
Thank you. Ali.
Thank you, Chair. It's a point about delivery. So it's a complicated plan. And I just wanted to note that the Partnership Board last Thursday committed to have oversight of the system delivery of the plan linked to the maturity of the NHCP architecture as it moves forward. So I suppose it's just connecting a complex plan, but also a very complex delivery mechanism. And we've got a commissioning function within that, but there is also an integrated delivery function, which leads into my ICS report, next agenda item. Thank you. Just a comment.
Thank you. Without wanting to spoil the next agenda item, I'm going to leave everybody in suspense on that one. Divaka.
I think this is labelled a recovery plan, but there is a lot here to take forward into life thereafter, into new normal or otherwise. So we talk about recoveries and efficiencies, but in terms of pure secondary care interaction, we have a lot of reliance now on face-to-face consultation currently, which is as the only option. But going forward, I think the importance of history taking and planning management on what you obtain from the patient is a skill that can be developed. So any plans going forward into interactions with secondary care and primary care could be, do consultants have to see patients face to face? Could there be decision support? Are things to be considered?
Thank you. That's very helpful, and I think it's helpful for clinicians across the system to make those adaptations. Thank you. So I'm going to move on with the next item on the agenda, which is, as much anticipated, Ali's element on the integrated care systems. Over to you, Ali. And obviously we have read the paper, so tell us what we need to know.
Thank you, Chair. In anticipation, so yes, take the paper as read. I suppose I'd like the governing body to note that this paper is a paper that's been circulating through all organisations, statutory bodies across the system, but it is the September Partnership Board report, and there is a more up-to-date report from the Partnership Board last Thursday, which we'll obviously bring to governing body next month. But I'd like to give an update on some of the recommendations and the things we've agreed within the partnership. So in the report you've got in front of you, I just want to make two particular points. So the ICS vision, it is clear that we have quite a lot of work to do as a system with respect to defining what that vision is. and that was discussed in the partnership board last week, and we are planning for a November workshop. There was going to be an October workshop, now it's progressed to November, but the point I'm making is it's really important that we are clear on our direction of travel as we develop the architecture of the subcommittees, which is outlined in the report. So we know our direction of travel as a system, and the recommendation in this paper is that we consider as a governing body what our role as a commissioner in that our integrated care system is, and we have some conversations maybe in our development sessions which we need to be clear on that as we develop our ICS vision for the system. So those are the 2 points I wanted to update on. The only final point is that the ICS programme and its delivery to become a thriving ICS for April 2021 is on track in line with the EI recommendations, but we do have to make sure we're clear on that vision as part of that process. So happy to take any comments at that point, Joe, and then maybe I'll brief at the end on some of the decisions that we have made in last week's partnership board, just to brief the governing body.
Thank you. Any comments or questions at this point? Philip.
Yeah, I haven't got many more comments to make this afternoon, but at the last meeting we had with Ali about this, the locality chair for Wellingborough and East Northants raised the issue of budget holding for locality board. I didn't actually make any comment at that time because I wanted to take soundings from the membership which I represent. But in terms of the structure, if you look at it on page 113, the System Finance Committee appears to be sort of sadly on its own on the side there. And the feedback I've initially had, and I have to say I have to take it back to the locality board meeting next week, but the comments I have all been very positive about the locality board being a budget holding organisation for community provided services. So that's excluding secondary care and tertiary care. But I did just want to raise that they are very keen to do that and to proceed at pace with developing that.
Thank you, Philip. Ali, do you want to comment on that?
Yes, I do, and that was part of my update from a decision that was made last Thursday in the partnership board. So there is a locality function proposition that's started to circulate through our system currently, and part of what Philip's describing is what would be the future functioning of that delivery unit at locality level. So that's about the analytics, it's about the resources, it's about its purpose within a population health management model. So it's a component of that future direction of travel at all levels of place. And I've been working closely with the GP chairs to develop that. So it's their proposition into the system, and that was endorsed to move forward for further development last week.
Thank you. Toby.
Thanks, Joe. Sorry, it's a bit of the Philip and Toby show at the moment. I'm sure we'll both calm down in a moment and let others come in. 2 quick points on this, though, because it's a really important block of work, and I'm so pleased to see it's moving again. It felt for a good while, actually, over kind of first wave that some of this work sort of stalled here and elsewhere across the country. So I'm really glad that we've managed to get Ali and team fully back on it. I'm delighted we've got, I'm going to reference it again, the independent chair appointed into this. It was so great actually to run that process and have local GP leads, local authority leads, chairs, chief executive partner organisations involved, and all those different stakeholder and interview panels come to the same consensus view in terms of what we thought Naomi could bring to work with us. Two quick comments on this. We all know there's further work underway nationally around kind of future models for integrated care systems and expectations in terms of policy direction. Amanda Pritchard, the National Chief Operating Officer, was briefing us on a call a week and a bit ago. to expect something out nationally in the next few weeks around the shape of some of that, particularly in terms of kind of commissioning functions within ICSs, around provider collaboration and around place-based decision making. I should say at this point, I and others are not expecting that to come out with something that surprises us all locally. We've seen and been involved in kind of roundtable discussions to help to shape and inform all of that. What I am expecting it to do is to reinforce the expectation that CCGs evolve into that kind of support structure, but at different levels of place in terms of that strategic commissioning function, providing that kind of planning, resource allocation, coordinating function that we talked about earlier on around phase 3 planning. But I think it will be significant for CCGs in particular when that additional national piece comes out in the next couple of weeks. So as soon as that lands, we will share that. And then the second linked bit, just to give a heads up, that we've been giving some thought over the last couple of months from an exec team point of view to how does the CCG's resource, and in particular, I mean, there are staff resource, both directly employed and also CSU resource, how does that evolve to support the different levels of the integrated care system at different levels of place? And in particular, looping back to Philip's conversation there around localities, how do we wrap and devolve more support to, from an officer point of view, to provide more support and capacity to the localities to enable them to do the things they need to do really well? Similarly, the integrated care partnership level, and also the overarching and overall kind of county-wide ICS level. So we have a internal workshop session we've set up for Friday the 6th of November in a couple of weeks' time, and I'll be keen to make sure that we can come and share some of our emerging thoughts on that with governing body, probably in a thinking time session, and hopefully if we get some of that national bit landing around the same time in the next few weeks, we can put those two things together and have a really good session about where we think some of that leans next. Thank you.
Thank you. Any other comments or questions? So I'm going to move on with the public health report. As ever, this is a lovely report with beautiful pictures, but so much more than just the beautiful pictures. We obviously have read that. I know a huge amount of public health capacity is obviously taking place with COVID, but there are so many other activities, and obviously the link with the wider health inequalities as well. So over to you, Lucy, if there's anything you want to draw our attention to, and then we'll see if there's any questions, possibly from Toby and Philip.
Well, in the interest of time, there's two things I think that just are particularly important. People, are aware of the work that we're doing around COVID. These are slightly different things. So I think this was brought some time ago as a proposal, which is a programme called Pause for a Fresh Start in Northamptonshire. So there is a national programme that we have signed up to, and it's part of a social impact bond programme. We've got Life Chances funding contributing to this. But locally, we're investing just under £1 million collectively into a programme to support women who have children repeatedly taken into care. And it's a supported programme to make them obviously reevaluate where they are, how they may be able to support the children and see the children in a productive way that are currently in care, but also to work with them to avoid repeat pregnancies overall, but certainly repeat pregnancies that may end up in a child being taken into care again. A second pregnancy or third pregnancy is not a failure if that child is then able to stay in that parent's care. And it's also about, as I said, trying to reintegrate the original family back together over time as and when is safe to do so. But it's a programme that's got a really good evidence base, a really good success rate in other areas, and we're really pleased to bring it to Northamptonshire. There are over 60 young ladies and mothers who have been identified as eligible for this programme, and we've already got 19 fully engaged in the programme in the first sort of couple of months of it being launched. So a really exciting programme of work, something we've never done before locally, and something that I'm sure will make a huge difference to those women and their children. The second is the very fiercely debated e-scooters. So I thought, I don't know if it's featured as much on the NHS Twitter pages as it has on the local authority Twitter pages, but NBC, so Northampton Borough Council, with Northamptonshire County Council, invested in a pilot where we have a number of e-scooters, which I'm sure people will have seen dotted around. This is obviously an opportunity to bring active and green travel into Northampton Borough. It obviously facilitates people being able to get around in a way that is safe from a point of view of they're not sat on a bus or car sharing from a COVID perspective. But equally, it is a programme that has met with some interesting behaviours. I think there was lots of excitement, and we may have found a number of scooters in various and interesting places over the first couple of weeks of them being utilised. I'm pleased to say that the initial excitement has died down. We're now seeing residents use them very sensibly. They are, as I said, a very good alternative green mode of transport, and we obviously are hoping, because pilots have been stopped elsewhere because of some of the antisocial behaviour associated with them. Very pleased that NCC and NBC have stuck with this, and we're now seeing lots of people utilise these for popping between different meetings, popping to and from work. And as I said, it's a sustainable and green form of transport where people are obviously able to engage in something that is also very COVID secure at the moment. So good news, but I thought something that was been quite interesting from a point of view of it's had both positive and negative responses in its initial launch.
Thank you. Some good and some slightly different news, so very, very welcome. Ange, over to you.
Yeah, I was going to talk about Pause Project, but I think I need a scooter now, so I'll be looking in Lucy's office. I just wanted to pick up on the Pause Project because I was really excited by that, Lucy, because I know in London there's been many projects like this and it really does make a difference. And speaking from somebody with a midwifery background, I really welcome that opportunity to break that cycle, because often children who have children will sometimes end up in those really difficult situations as well. And I think also when we're trying to work with women who may have an addiction to a substance, could that be drugs or alcohol, they get into sometimes to spiral out of control. So these programs are so important, Lucy. So I really welcome it. And I'd be really great to work with you with the heads of midwifery as well, and also our health visitors, because these programs, it is about keeping the momentum going. But I'd just like to say it's really exciting because I know they've really made a difference in parts of London, breaking the cycle and working with big organisations like King's and the London hospitals. They've noticed a real difference in terms of when they have them women presenting with difficulties in pregnancy, because a pregnant lady who's taken substance is very difficult. But if you can break the cycle and get people more taking ownership of themselves, it really makes a difference. So I just want to say this is a great project for Northamptonshire, Lucy. Thank you.
Thank you. No, it's really welcome. And you know, I think it's important for us to be aware that public health is so much more than the COVID response, and we are grateful for all of the efforts involved. Any other comments or questions? So thank you. So the next item on the agenda is item number 13. So that's the delegation of financial limits. This is an item that Stuart is presenting. There is obviously quite a lot of detail. I have got one specific comment, but I'm going to let Stuart point some things out before I make that comment.
Okay, thanks, Stuart. I take the paper as read. This paper on the financial delegates is simple, as in basically what we're asking is to reinstate the financial delegation limit of the CCG pre-COVID as a normal running of business. We did change that for COVID. We also then went to the step of, if COVID was going to kick off again, we would put exceptional circumstances where myself and the chief exec would step in and reinstate some of the stuff. We've had discussions at committees, both at Audit Committee, Finance Committee and CMT. We haven't used any of these exceptional circumstances or needed to, all within the normal parameters of delegations. We're just looking to reinstate them. And I'll stop at that point, Joe, and take your question.
Thank you. I think there's one slight error on page 158 that refers to a deputy GP chair. I believe I will speak to you outside the meeting, but I will nominate you another GP to be the authority from that point of view. But we obviously don't have a deputy GP chair at this particular point in time. But as I say, other than that, any other comments or queries on this agenda item? Okay, so this is for noting, and so we have indeed noted it. Thank you, Stuart. So this is the Stuart section of the agenda. So we're going to go on to item 14, which is the finance report. Over to you, Stuart, again.
Okay, thank you, Chair. Again, this is quite simple. I'll take the paper as read, but this would describe, as Toby described earlier, we were still working in the regime where we would retrospectively claim funding back from the centre over and above. We did at month 5 report a 1.88 million overspend. Most of that overspend was purely related to COVID, prescribing, and a bit of IPCs. We had some underspend offset in some of that, but I can confirm that all that money has been funded at month 5 nationally. So the CCG ended up at month 5 break even. And I'll stop at that point and take any questions.
Any questions? Everybody's obviously happy with that. So if we move on to the financial plan, which is item number 15, your stage, Stuart.
Thank you, Chair. Now, this will be an update because, as people will know that are close to it, I submitted on behalf of the system just before noon today again. So, linked to what Sarah was saying earlier, we did submit a narrative alongside in September. We then had to submit on the 5th of October. We then had to submit again today the system plan, and we will submit an organisational plan on the 22nd of October, and that'll be all the health partners in the system. So this, as this paper highlighted at the time of writing, we had posted a 26.8 million deficit, which came down with SDF funding, strategic development funds, to 22.6. What I can say is that as of today, what we have submitted, and this will be quite sort of live, so it went through a number of processes. We'll be having meetings across the whole system to get this. So something that the Director of Finances have just made up on their own. We have been having meetings with other parties, just to be clear. So we have now submitted basically a 9.9 million deficit for the system. Now, there are some complications to that. The template would show a 12.7 million deficit. The difference being not all SDF funding is yet confirmed. You have to apply and get it, but we think we would get it. Also, the PCN additional funding, they're keeping outside of the template at the moment. So that is 2.1. So they're the main differences to what the template would say and what we're saying as a whole system the deficit would be. The main implications of the deficit are there is an expected, and I say expected, income recovery for providers to get income into the system. And this would be relating from car parking to canteen services to shops they have in their buildings. Of that 9 of the expectation, we will not achieve 8.4 million of that expectation. So it's by far the biggest part of the deficit of the system. And that is what we've agreed to submit today across the patch and have done so. And I'll stop at that point and take any sort of detailed questions, but noting this was live, worked right up to this morning across the patch.
I very much appreciate everything that you and your team are doing. There are many submissions with many tight deadlines, and obviously our gratitude to all of them for so far making all of them on time, and much appreciated. Any questions or queries? You have once, oh, Toby, I was about to say you've stunned them into silence. Toby, thank you.
So Stuart, thanks for providing the kind of very latest update. Worth noting for board colleagues that position is submitted literally today as a system submission. Individual organisations will make returns on Thursday that will be consistent with that. Having been on a Teams call yesterday morning with Mark Mansfield, our Regional Finance Director, and other regional colleagues, I'll be surprised if there isn't still a degree of, well, firstly, the progress that's been made to get from 20 plus to the kind of 9-10 number will very clearly be welcomed and well recognised. So, and I'd just like to put on record, actually, the finance community across the county has worked, and all of us, I think, recognise from a chief exec point of view, has and continues to work in an ever increasingly kind of open way across it, which is not something we've always seen here and elsewhere across the country. So that is a good place to be. But I'll be very surprised if after this round of submissions this week there isn't still a further conversation to be had with regional colleagues and our regulators around that position, and in particular whether it isn't possible to close that further difference between our return position today and the 8.4 or so number that reflects where we would be in terms of that income difference number. The reason for drawing that to governing body's attention is that we looked earlier on at the phase 3 plan submission that Sarah talked us through, and to date the finance plan has been built very bottom up on the basis of what do we think the actual costs are to give us a good prospect of being able to deliver all of the things within that plan. And therefore to date we haven't traded off delivery and performance against financial position. If we're required to go further in terms of the financial position, I think we're all pretty much of a view now, Stuart, that we've got to the place where we don't have easy options in terms of being able to do things that won't have a consequence, either in terms of particularly elective activity and restoration and recovery, or in terms of our confidence about resilience and capacity to cope with winter and COVID and flu and so on. So we're heading into the arena of no further, not that anything to date's been an easy choice or trade-off, but these things now would have direct knock-on impacts if we are asked to go a bit further in that. And I flagged that partly, Joe, from the point of view that I think if that's where we do head and we are asked to go, we may want to think about how we hook some of our lay GP and possibly sort of chair input into any of those choices we might then be making, because at that point we're into direct patient consequences, either of access to treatment or in terms of risk of going a bit further. But to date, thankfully, we've managed to make that very good progress without needing to stray into that territory. Thank you.
And I think on the back of that comment, it's probably worth noting that clinicians are meeting across the system and actually developing common clinical risk registers, working out what the greatest risk is to our population from a health point of view. So neither finance nor clinical risk can be taken in isolation, and it is important that we work together across the system. And certainly the foundations for that are very much in place should we need them. Andrew.
So yeah, just building on that, Toby. So obviously it's fantastic that the finance teams are working together. In terms of that, we're getting to the point of impact if we have to make further savings. Are we aligned in terms, or have we got means to be aligned in terms of what those impacts will be? So do we have a consistent view across the sector in terms of which is the first thing that would go? Because I think there is a danger that we all end up sort of doing a bit of a knee jerk if we're asked to find more savings. It would be good to have a position that was jointly agreed across all of the partners. Is that something that's in train at the moment?
It's in train, so we have a commitment that if we are going to, if we need to go further than what's been submitted today, we will only do that if we do that jointly together and we understand the consequences. There is a session tomorrow afternoon informally between NHS chief execs to just think through a bit where do we think we might go next if we need to. And I suppose we should be clear here, it's actually possible that our regulators come back and say, thank you very much, you've done a really great job to get to that point. A lot of other counties around you are not in that position and a very different set of numbers, and therefore we may be able to carry on. It's more just raising the possibility that that's where we may go. But yes, Andrew, in train and commitment that we do that collectively rather than unilateral decisions by individual organisations that have unforeseen implications for each other. That's not where we're going to go. Sorry, Stuart, I've answered what you probably were about to.
Teamwork, perfect. Any other comments or queries? Thank you, Stuart. That is your bit of the agenda over with. So going back to Sarah, we've got the contracting and procurement report. That's obviously got quite a bit of detail within it. I'm sure everybody has read the paper. Is there anything you'd particularly like to draw our attention to before we open that up for questions?
Just a couple of things, Joe. Thank you. So the first is just, I think since last we met, new guidance that is very clear about the necessity to hold contracts with other NHS providers for the rest of this year, and that formal NHS standard contracts with NHS statutory bodies won't be required. So contracts, for instance, between us and NGH, KGH, NHFT. Obviously, certain other contracts continue to remain in force, and the contract with the independent sector currently still being managed and negotiated nationally. But since this paper has been written, some more information about the national framework that is likely to go live in early January in terms of commissioning the independent sector for the rest of this year and probably next. And we'll bring some more information back on that when to the appropriate committee, actually, in terms of the detail there. I think you will continue in the detail of the tables to see the activity challenges across the system. But having said that, I think it's important to note that given all the discussions we've had, activity within September was very close, if not exceeded in most respects, the phase 3 planning ambition. It didn't necessarily get as far as NHSI's target of 80%, but actually, other than I think for elective inpatients at one of our acute providers, all targets, all planned levels of activity have been delivered for September within our system. As everybody said, a significant challenge in terms of the maintenance of that as we move forward, and various trade-offs that will be part of the conversations we've described. And therefore, the kind of caveat on all of that is we all know that pressure on the system is rising, and therefore the management of that as we move forward from an activity point of view will be key as part of the NHCP conversations, the phase 3 conversations, etc. That was all I was going to say on this report, Joe. Happy to take questions.
Any questions or comments for Sarah? Toby.
A comment, Sarah, back to your point on independent sector. I understand why we've not, and sorry, this isn't something we've rehearsed, but I understand why we've not kind of factored this into report to date in terms of how it's put together. My sense is that nationally we're going into a period over the next few months where there will be increasing scrutiny, rightly so, on how the level of capacity within our independent sector providers is being utilised. Almost, actually, whether that's a contract that continues to be held centrally and nationally, or whether it's something which is deployed locally. So I think it will be appropriate for us to look at how we can factor something into our contracting report that reflects the delivery from particularly those two providers in terms of our own local patch on the IS side of things, so that we're cited on levels of utilisation of capacity that has been NHS funded within Northamptonshire. I know I can see Ali's hand's gone up, so I know this is something the elective care work is rightly tracking, but I think it'd be important for board to be cited and for that to be visible, because I do think we're going to find both nationally and regionally this becomes a bigger thing as we go through autumn and winter. Going back to my point about how tight everything's got, this becomes one of the few kind of buffer places we've got to still be able to go in terms of pressure. Thank you.
Sarah, did you want to respond?
Yeah, I was just going to come back to Toby's point. Really happy, Toby, to consider how best we present that in terms of committee structure and the board information. Just as an update for colleagues, we get from NHS EI a weekly utilisation report on the independent sector within the county, reflected back to us. And it is the case at the moment that Northamptonshire planned to use most, if not all, of its available independent sector capacity under the new contracting arrangements, and that certainly for the past month or so we have either delivered or been in excess of that activity. So currently, I think, just as kind of soft intelligence, we are utilising that capacity as we plan to, and we plan to utilise most of the capacity that was available. But happy to bring back some more detailed exposition of that in terms of the contracting report for future months.
Thank you. Ali, did you want to comment?
Thanks, Chair. I've put a comment in the chat around the system elective care group in response to what Toby's just referred to. I think we still could use the independent sector in a different way. as when you look at it from a system perspective for the whole, for both acutes, not just for one acute, if you think of a group model, and that's part of where the elective system group is progressing to. So I think we've got to where we've got to, but we could do more if they're much more integral, and actually they're very keen to be more integral in that forward thinking, hence why we're setting up the system group.
Thank you. Any other comments on the contract and procurement? Thank you. So we're going to move on with the next agenda item, which is the Quality, Safeguarding and Performance Report, which is, as ever, a fabulous double act, with the first part from Ange and the second part from Sarah. So, Ange, do you want to take us through the quality and safety aspect first? Then I'm going to pause for questions, move on to performance, but obviously they are all intimately related. So over to you, Ange.
Yeah, thank you, Jo. Yeah, so the report's in two parts, so I'll start and then hand over to Sarah. So just to keep you appraised of our second Quality and Safeguard and Performance Committee, which was held on the 15th of September. So this was the second time we'd held the committee in this format. We'd started just before COVID, around about March, where we changed the format. And this was in line with what NHS England I recommended that we did in terms of combining quality, safety and performance. So I'm pleased to say the second meeting went extremely well. Our attendees said they enjoyed the new format, and in fact it allowed them to share ideas and learn from each other much better than what we'd done previously. So I'm pleased to report on that. I'd like to just pull out some areas from the report in terms of what we're doing around cancer breaches. So we're continuing to monitor any 62-day or 104-day breaches. And this is taken through our countrywide cancer improvement group. So this is on the agenda as a standing item. And of course, the quality and safety teams are reviewing this on an ongoing basis. Our quality and contracting teams are working together to review any potential harms for any patients who've waited longer than 52 weeks for elective care. I'm pleased to say we haven't had any reported to us, but we've also extended that. We're working with any of our providers that are outside our boundary to see what their clinical harm review processes are as well. And we've had a really positive response from the neighbouring hospitals that we've had harms as well identified. I'd like to just talk a little bit about what we're doing around care homes and domiciliary care, because jointly we've been working very closely with our colleagues in Northamptonshire Adult Social Services. So we've been working closely on initiatives around IPC, which we've spoken about already at the governing body, but also that through the care home cell where we meet weekly, which was held this morning as well, we are really trying to break down what it means for care homes now, what is important to them, and how we can as a system work collectively to support them. Also, I'm really pleased to say that we've got a provider-led domiciliary care provider forum. It's in its third month now, and through COVID, this has come about, which is a real positive for the domiciliary care market. And we've got about 15 providers part of this now, and they're using it really to share learning, talk to each other, and also about working with us, especially around home first. So that's really good. The quality and safety teams are also working with care homes to evaluate how the GP virtual visits are going and what the ward rounds have been like. So in the report, you'll see we've got a new risk indicator tool. So we're just working with the homes now around what it means for them, what it looks like. So hopefully by the next governing body, I'll be able to give you a report on that of what we've found. Tomorrow also is really exciting for our team because we're putting on our first training around the pulse oximeters. And it starts in a care home tomorrow. And what we're trying to do is capture all training. So be there in the morning, in the afternoon and the evening, so that we can capture all different shifts within the care home to provide that training. And also yesterday, I'm pleased to say we put on additional IPC updates for over 35 care home managers. That's been recorded, and it's something that we know care homes really like in terms of webinars. So we'll keep pace with that training, building on all of the face-to-face training that we did over the summer. So Jo, I'm just going to stop there because I just wanted to pull out the key highlights really. There's lots in the report, but I'm sure some of my colleagues might want me to expand a bit further.
Thank you. I'm going to use Chair's prerogative and make my comment first, which is I think that while we are focusing on COVID, I think the recognition of clinical harms is really important. And we know there are still some patients who have been too terrified to present with their problems to their GP or to any other health professional. And we are mindful that actually we need to be vigilant as clinicians across the system for people who have waited too long, encourage those people to present appropriately at their own registered general practice. And we are seeing heartbreaking stories of people who present with very advanced cancer, knowing that they've had symptoms since March and being too terrified to come out. And I think it is something that concerns a lot of us. We are worried about it and continue to have the campaigns to make sure that people are aware that services are there and that harms may come to people from factors that are within our control within health and care services, but also there are factors that are related to the patients that we care for and their carers, and is something that we need to all be vigilant about as we move through these next few months and particularly into a second phase. I'm going to take the questions in the order that they appeared, so over to you, David.
Just quickly, just to reinforce the point you just made, it has come up through HealthWatch a number of occasions. If there's anything that we can do to help, we've already made comments about don't hesitate to come forward if you have a concern, but it is really worrying and significant. The second point is a question to Ange, concern about the care home and indeed nursing home market and the vacancy rates. And that could have serious implications for hospital discharge and others. Is there any intelligence about what's happening there? That would be helpful to know. Thank you.
Jo, can I respond to that? Yeah,
please do.
David, we had that same conversation this morning on the care home cell, because you know we've got the capacity tracker, so we can see where the vacant beds are. One of my colleagues, Raf Pogi, GP, raised that very point this morning, which we discussed. So it is on our radar, David. We do talk about it. We've got the capacity tracker, and I think as a system now we are having those conversations about what we learned from the first wave and what we're going to put in place now. But further down the line, I'll be able to share more detail with you once we start building on that piece of work.
Sure. I mean, the issue obviously is people, it's the same as not going for treatment. People are concerned about moving into the next stage of care, and at what point I've had personal experience of that. And finally, and thank you for the work you've done encouraging the care homes to come together in the forum. I know from other counties how difficult that is. These are often independent, incredibly competitive and suspicious of each other, but actually coming together in a forum is very constructive, and that's really good system work. Thank you.
And just to come back on your first point, David, yes, we'll be in touch. Anything that we can do to work with HealthWatch for our population, I'll give you a shout. Ali, do you want to come in?
A couple of questions from me. It goes back to the section on the serious incidents, and I can see that particularly our community providers get a high number of serious incidents, and I wanted to check back and how that's then, whether there's a connection to performance, hence the performance and quality component of that, and then visibility. And is the trend going up or down? I couldn't quite gauge that from the paper.
Okay, yeah, I can answer that, Alison, because obviously NHFT straddles two camps. It's community provider as well as mental health. So without looking at all the situation information behind each one, it's probably a mixture of both mental health and community. Can I just do a sense check, Alison? Would you prefer more information in the report on that, or? I'm just thinking, linking, because I'm just thinking behind each serious incident, obviously we do a root cause analysis and there's a lot of work behind each serious incident. So in actual fact, sometimes it fluctuates, Alison. We may see more smaller incidents at KGH and NGH. In fact, at NHFT normally is a bit smaller on that. I'm just thinking it could well be it's a mixture of mental health and community provision on this occasion, but I'd have to look a bit more deeper into that.
Yes, it wasn't the detail, it was more the connectivity, trying to correlate between performance and quality from a CCG oversight, and then how you link it back to the system.
Yeah,
I can pick it offline with you, Ange.
Yeah, I think it's because we've done a lot of work with our providers in terms of reporting on SIs. So we've got really positive relationship in terms of sharing all information, Alison. So in some respect, seeing SIs is a good thing because providers are reporting on their serious instances. So I can pick it up offline on you, but in actual fact, NHFT normally may have a little bit lower, but that's in line because they do report on quite a few incidences.
And I think it's probably also worth mentioning some of the conversations that Andrew and I have had about supporting primary care to recognise SIs, particularly those that have interrelationships across the system, where patients have had contact with multiple services, that actually many of our primary care colleagues are the eyes and ears of the system. And I think it's really important that we don't miss the opportunity to learn from SIs that are recognised and only recognisable in primary care because they may not touch other parts of the system.
Yeah. And just to pick up, the SIAM groups actually look at trends analysis and compare with other regions as well, Alison, in terms of what do we look like in comparison to other areas. And I don't think we're an outlier, but I can pick this up offline with you.
And Chair, just for clarity, the elective care conversation we've just had, it's seeing whether the connectivity of whether we've got the long waiters contributing to our SIs, for example. It's that type of sort of connectivity. So I think it's probably because we're developing the connection of performance into quality, but I think we do need to take a different lens on it. That's where I was coming from.
Thank you. I think an important point to note. Toby.
Thanks, Chair. Different topic, quality related. Just wanted to pick it up to make sure we were all cited on this as a governing body. The Care Quality Commission are currently working across Northamptonshire as one of, I think, 8 from memory, STP and ICS areas across the country, undertaking what's described as a provider collaborative kind of system review, looking at how providers across the county, and that's not just NHS provider trusts, it's looking at primary care, it's looking at care homes, it's looking at the whole kind of provider response, has been working in terms of urgent and emergency care through the last kind of 6 months in particular in terms of that COVID response period. That will result in both a national report that draws themes out from each of the 8 areas that they look at, but it will also translate into a Northamptonshire specific report that we will receive, which will give feedback back into our system. It's not a rated assessment, so it won't result in an overall ratings view, but it will, I'm sure, be something that we would all welcome in terms of that kind of holding the mirror up and playing back to us as a system how different parts of our area have been working. And I know quite a lot of people on this meeting will have already been interviewed by the CQC team as part of their work, but I think it will be significant in terms of their reflections they play back to us. It's something I certainly very much welcome and look forward to seeing what they come up with. But thank you also to colleagues who already contributed to the exercise that they're running.
Thank you, Toby. So we're going to move on to the Sarah part of the report, which is the performance element. That starts on page 204 of your pack for anyone who's lost their way at any point over preceding minutes. And then we'll have a little bit more time for more questions. Over to you, Sarah. Obviously, we have read all the detail.
Thanks, Joe. A lot of information in here in response really to the request from governing body last month to stand back up some of this standard reporting. I'd just acknowledge a couple of limitations, Joe, and then I'm happy to take questions. This is in essence, our members will recognise it. This is our previous reporting pack stood back up again. So contains performance against a number of constitutional standards and system standards that haven't been superseded but have been added to in terms of the phase 3 recovery requirements. And this report hasn't yet got to the point where it's matured enough to measure all of those. So some of these are not as helpful as they might be or will be over the coming months as we manage to integrate some of the phase 3 reporting requirements in here as well. But what you will see inevitably against a number of the standard reporting metrics is a deterioration across the system in performance. As we've briefed in previously, that won't be a surprise. But as I say, the positive message that I would wrap around that, which you don't get as much from this report, is the delivery of the planned activity for September to its planned level for the most part. And therefore, whilst this performance picture isn't a happy one, the planned recovery piece has largely been delivered as we planned. And I'll just leave it there in terms of going through the pages in detail, but I'm happy to take questions if anyone has any. And we will iterate the report going forward so it's more useful in the wider phase 3 context.
Thank you. Any comments or questions? I think so. They feel they have enough information. So thank you. That's really helpful. So we're going to move on with the next item on the agenda, which is the much anticipated annual workforce race equality standard report. Generated quite a lot of activity and excitement last year. And obviously, Satvinder has a tough act to follow. And I will hand over to you. And obviously, we have read the paper. So over to you, Satvinder.
Thank you very much, Chair. Sorry, my camera's not coming on, but if you could just bear with my voice. And I suppose I take the RES report is as read, and just a few points I like to make before before I ask you to ask me any questions. The RES report covers the last year's data from April 19 to March 20. And it details the progress against the race equality standards, 9 data matrix, and capturing actions taken and planned actions for the next year. The report has been approved by the Quality and Safety Performance Committee. The report has been shared with the weekly staff briefing. Now we seek your approval, and following governing body's approval, this report will be internally published on Northamptonshire's website by 31st of October, in line with the NHS, England's national NHS RES publication timelines. So I'm happy, Chair, to take questions from you and the panel, and I'll do my best to answer them.
Thank you very much. Sarah.
Thanks, Joe. I'm just to add, really for context more than anything else, because this is one of the things that came up when we briefed colleagues on our weekly staff briefing last week. What you've got here is a kind of factual report on a set of predefined standards and an action plan to deal with those. And it's the right report. And because of a number of the things that we measure, because of the type of organisation our organisation is, because of a number of quite small numbers, you don't necessarily get, for me, what's really important here is the lived experience of colleagues in this space. And the RES report on its own probably isn't, from a personal point of view, enough in this space. And so it's really just to flag to governing body members that we recognise that, and that whilst this is a functional exposition of something that we have to measure from an NHSE and regulator point of view, that actually the OD and cultural work within the CCG over the coming year also, as I say, needs to focus not just on what we can measure, but how it feels in terms of race equality within our organisation, in terms of what it's like to be a BAME member of staff within the CCG. And therefore, what, if anything, in that space we need to take as actions in that regard as well. I just wanted to give that kind of rounded context to it before we took questions.
Thank you, Sarah. Andrew.
Yeah, that's really reassuring. So I think that it's great to have the data. My sort of feeling builds on what you were just talking about, which is really understanding the interventions we can make. I think it's all very well measuring something, but actually understanding what we can do and how we can sort of, rather than compartmentalise, how we can actually make it part of the whole diversity and inclusion agenda and build that into the culture. I think that there is a danger that we look at these in individual compartments. So brilliant to have some metrics, brilliant to have some data. Really keen to see the so what beyond sort of it's understanding those interventions and how we actually support it as a ongoing change in that culture.
I'm going to take a couple more comments, if that's okay with you, Satvinder, and then perhaps if you're happy to comment on everything that's been said. Sam, do you want to just comment or question?
Yeah, thank you. I suppose I echo Andrew's comments a little bit, actually. So great that we have the data. What I wanted to see a bit more of is the action plan. The action plan for me doesn't feel meaty enough. There's not enough kind of really key deadlines. It doesn't feel even smart enough. So I'd really like to understand how we're going to keep up to date with it, how we're going to keep reviewing it, how we make sure that it really is at the front of our minds all the time. And it is, because it's something it is that is really important to us at the CCG. So I just want to make sure that the review and the kind of process around the action planning is really robust.
Thank you. That's helpful. David, do you want to comment?
I think we discussed this last year in Corby, didn't we? I seem to remember I made some comments at the time, and I'd endorse what other colleagues have said. This is such a crucially important time for this area of work. And it needs clear action, even albeit the CCG is a small workforce, but more importantly is the signal it sends to our wider workforce and to our wider communities. And it's the messages to the community that are important. Probably this is stretching this issue, but HealthWatch is actively beginning to think about how we should engage more significantly with Black and minority ethnic communities, and interested to explore that. If I can just throw that out there with others, it's clear in COVID how important this has been. This has been quite a challenging issue for us in the COVID context. To be blunt, I don't think the county has done particularly well in its history of dealing with these issues, and we need to be far more actively engaged with it. So again, HealthWatch is interested to explore with others how we can engage with communities. People often say they're hard to reach communities. Really, that's because we haven't made the right effort, and we have to work harder to achieve that contact. That's beyond the staff issue, but about the community. It feels, I was in a meeting this morning with the Commonwealth, an international meeting, but talking about racism within the Commonwealth and elsewhere. This is, feels to me incredibly important for social stability and for our communities. And we really just have to apply ourselves to it in the way that other colleagues have said. Thank you.
And take one more comment from Bev, and then Satvinder, you may wish to come back on those comments, and then we'll have any more after that. Bev, do you want to come in at this point?
Yeah, thanks, Jo. I guess I'm just doing a bit of reinforcement of my lay member colleagues and David, actually. So really supportive of the data, but you know, the data on its own, as Sarah said, is not enough. It needs triangulated with that real life experience internally. And we were talking this morning at the Strategy and Planning Committee about where some of the